Good day, everyone. My name is Mark Fendrick. I'm a professor of medicine and a primary care physician at the University of Michigan, where I direct the University of Michigan Center for Value-Based Insurance Design, and am extraordinarily pleased to attend this BMA panel entitled Building a Better Health System Through Value-Based Care. And we are incredibly fortunate to have three uber experts on the area of value-based care to join me over the next hour to discuss where we've been and where we're going. Lots of very exciting innovations have been discussed over the first day at the BMA Summit already, and we're very lucky to have these three panelists to help us put it together. So I'll start with some opening remarks and be followed by my colleague Jeff Micklos from the Healthcare Transformation Taskforce. He'll be followed by Tim Berry of VillageMD, and our closer will be Jay Keese, as some of you might know from Capital Associates, who is currently the executive director of the Primary Care Coalition. So as someone who has been both seeing patients and doing health services research and outcome research for now in my fourth decade, it's been made clear over this day so far that healthcare costs are a top issue for patients, clinicians, and policymakers. And as we've gone through the day and as we all do our work, solutions must protect consumers first and foremost, but also reward providers, and we'll hear a lot from the provider perspective from our panelists, as well as preserving innovation, which is a topic near and dear to my heart that's been debating almost daily on Capitol Hill. But what I like to say as a clinician is that it's a remarkable time to be practicing medicine. The innovations to prevent, diagnose, and treat my patients and Medicare beneficiaries have led to impressive reductions in morbidity and mortality. But as you look at this conference or any other conference, irrespective of these advances, cutting healthcare spending seems to be the main focus of these discussions. And I like to tell people, I didn't go to med school to learn how to save people money. This is particularly true as we think about Medicare, as well as commercial payers, that the underutilization of the things I beg my patients to do, the things that make individuals and populations healthier, are always substantially underutilized. And thus the tension between the conflicting goals of improving health and saving money are here and will only get worse. And I think it's particularly interesting over the past few days, and certainly in an element in this new administration, the emphasis on reducing healthcare disparities and enhancing equity, and that we all know that a community of color have lower access to evidence-based clinician visits, diagnostic tests, and medications that do play a critical role in improving individual and population health. So as we turn to solutions, and I think that's what this panel is largely going to be focusing on, the good news is almost everyone agrees that there's enough money in the US healthcare system. That as we approach $4 trillion, we're not asking for another trillion that we should be spending on healthcare in the US. I think what we're going to be focusing on is that we spend a lot of this money on the wrong services, on the wrong people, and in the wrong places. And that moving from a volume-driven to a value-based system requires not only in how we deliver care and how we pay for care, but also to engage consumers to seek care, which has really been the focus of my work. So as we emerge, hopefully, from the COVID pandemic, can we turn this crisis into an opportunity? And I feel that going beyond talking the talk and walking the walk around the alignment of clinically driven payment reform, provider-facing initiatives that we'll talk about today, as well as emphasizing the new technologies, wearables and telemedicine, as well as alterations in benefit design, my area of interest, that will hopefully reallocate our money so we get more of the good stuff and less of the bad stuff. The fact that if we move the money around, I think we can improve patient-centered care, I think we can enhance equity, and I think for the payers out there that we can enhance efficiency. But we'll talk a bit, Jeff, Tim, and Jay will talk about more supply side or provider-facing initiatives. I'm going to talk just a little bit about my work on the consumer side, and that as we talk so much about healthcare costs, it's important to consumers that Americans really don't care about healthcare costs the way we all do. They care what it costs them, which is why I have been focusing primarily on out-of-pocket costs, whether they be co-payments, co-insurance, or what I view as the dreaded deductible, in that they're the ultimate blunt instrument that deter my patients from getting the care I beg them to do. And often these are services that you all are benchmarking me on. For example, an eye exam for a diabetic patient, coverage for eye exams in the US is actually worse now than it was when I started studying this high quality intervention in 1987, largely because the advent of deductibles. This may not be as big a problem in Medicare as it is in commercial, but it illustrates this idea that it's really important for us to align the amazing interventions we're doing on the payment reform side with how we're trying to engage our patients to do well. And I think in every talk, and some of you might have heard this, in my pushback on skin in the game, I always call on my 87-year-old mother who said in the year 2000, I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it. So while I appreciate transparency, I appreciate accountability, I don't believe that my Medicare patient should have to have a bake sale, give up on her rent or her transportation, or go to a charity to be able to afford a medication that was designed to treat her cancer. So we've been working very hard to remove some of these blunt instruments in Medicare and commercial payers and have clinically driven type of benefit designs that are aligned with some of these new quality-driven payment reforms that we'll talk about in a minute. We call this idea value-based insurance design. For those who've never heard of VBID before, it sets consumer cost sharing on clinical benefit, not price. And it's been implemented by hundreds of public and private payers, including Medicare. And the evidence is quite strong that if you make people pay less for something, they'll buy more of it. And in the trials that we've seen of value-based insurance design implementation that have looked at socioeconomic status, VBID has clearly been shown to reduce healthcare disparities. So for those who don't know what VBID is, and I'll wrap up quickly now, is that the ACA has mandated that certain preventive services be mandated without cost sharing. Hopefully all of you have experienced a high value service that will be provided to you at no cost. And most people don't know that in the 2020 CARES Act, that it was actually the VBID part of the ACA, Section 2713, that was amended to provide all of us who wanted to get a COVID vaccine at no cost to us. So there's a good example that we deem seems to be something so important, it is not going to cost any of our patients anything out of pocket to get the care they need. So quickly to turn to Medicare and Medicare Advantage, specifically, the Better Medicare Alliance has been strongly supportive of our work to implement value-based insurance design in the Medicare program for over a decade now. And we were very lucky, I think, all of us, to be presenting one day after the CMMI 10-year refresh, bringing attention very briefly to the Medicare Advantage VBID model test, which customizes supplemental benefits by reducing cost sharing for high-value services and providers, and allows some very exciting supplemental benefits that I think we'll talk about that are non-health related, like nutrition and transportation example. And CMS projects that over 3.7 million beneficiaries will receive VBID-type benefits designed to manage their conditions and address social needs, from food insecurity to social isolation. So showing a socioeconomic determinants going far beyond what is viewed as traditional medical care services. And the last thing I'll bring attention to, which was also highlighted in the CMMI refresh yesterday, is something called the Senior Savings Plan, which was a program introduced during the Trump administration that lowered out-of-pocket expenses for insulin for specified enhanced Medicare Part D and MA prescription drug plans. And we were very excited to see that CMS anticipates over 2,000 prescription drug plans participating in this voluntary program. And it is my hope that we will see lower out-of-pocket costs for Medicaid beneficiaries who not only require insulin therapy, but other potentially life-altering and life-saving therapies. So I'm optimistic that we're going to see an expansion of value-based care, specifically in value-based insurance design. And in the refresh, it basically said the VBID model is a critical lever to test payment and service delivery model to shape the trajectory of health equity. And importantly, for those of you from Medicare Advantage organizations, they also suggest there's a strong business case for Medicare Advantage organizations to participate in the VBID model and leverage CMMI's waiver to address healthcare disparities in a better way. So that's my overview about what we've been doing primarily on the consumer-facing side with value-based insurance design. And I'm very pleased to turn the virtual mic over to my colleague, Jeff Micklos. Jeff?
Thanks, Mark, and thanks for your decades of leadership in the VBID space. It's critically important to kind of the value-based care movement overall. Thanks also to BMA for the invitation to participate again in your summit. I really appreciate that. As Mark indicated at the outset, I'm Jeff Micklos. I'm the Executive Director of the Healthcare Transformation Taskforce. Taskforce is the private sector consortium dedicated to accelerating the pace of value-based transformation. Our members include health plans, providers, purchasers, and patient groups, and we're active in supporting and advancing value-based payment and care delivery models across all populations, Medicare, Medicaid, FEHBP, and commercial. We like to think of it as a friendly horse race, and which horse we want to push into the front. I think really Medicare Advantage is a primary driver of healthcare transformation right now, and we're really excited to be part of the efforts. So Task Force has been around for 7 years, and in our early years, our work with our health plan members mainly focused on how to make value-based transformation go in the commercial market. We also focused on what could be learned and transferred from the Medicare demonstrations being operated by the Center for Medicare and Medicaid Innovation, and what could be applicable to the commercial space. That commercial transition hasn't gone as fast as many would like due to a variety of factors, but principally because private purchasers and employers have not driven the demand in the market on a large scale. But over the past few years, we've observed and shifted our focus to the growth of value-based care and Medicare Advantage. Risk contracting is not a new concept, of course, but the way in which the financial incentives are being aligned with value-based care delivery objectives can be quite different today. And obviously, the growing market share of MA penetration means that everyone is paying attention. You see more provider-sponsored plans in addition to expansion of current health plan participation. And within our provider membership, we have watched over the last 5 years the increase in their participation and focus on the MA space. Obviously the platform provides great flexibility to operate while also being predictable and scalable, given that Medicare is the largest national payer. I see the other factor I think that's impacting the growth of value-based care in the Medicare Advantage space is what is happening in original Medicare, because value transformation there has not been as quick or as scalable as many had hoped. The Medicare Shared Savings Program is a bright spot, has growing attribution each year, and has generated significant savings for the trust fund. Yet CMMI has only been able to expand 4 models over this first 10 years. And there are many reasons for this. And some of the major ones are structural and how the governing law was designed and is being interpreted. All of this has led and contributed to major growth and focus on MA as an effective value-based driver. I think as we go through the session, we'll touch upon some other areas, but clearly the pandemic experience has also driven kind of interest in the MA model and the flexibilities. Some of the business models that you're seeing emerge in the transformation space, where there are organizations, several of whom are members of the task force, that allow independent physicians to continue to practice independently, has been a great opportunity. And as Mark alluded to, kind of the expansion of the Supplemental Benefit Authority and its implementation over the last 3 years have really been critical. As we think about new priorities for the current administration with regard to affordability and health equity, obviously, health plans are going to be a critical piece of how we drive in that direction. Health equity is obviously a goal that we all agree on, however, very difficult to get at. And so we'll have to work really quickly to be able to get that going. But we also want to make sure that the value-based progress that's going on in the marketplace today continues. So thanks again for allowing me to be here. And with that, I will turn it over to Tim Berry, CEO of VillageMD. Tim.
Thanks, Jeff. Really appreciate it. And Mark, thanks for including me on the panel. And very special thanks to BMA as someone who used to run a large Medicare Advantage plan and now lives at the intersection of care delivery and value. I'm thrilled and tickled to have the chance to speak today. I'll apologize in advance. I will have to run to catch a flight at some point in time, so I might move from video to audio, but I appreciate everyone's flexibility as things can be pretty fluid when you're living at the world that we live in. So with that said, I think that, Mark, you made some really great comments in your opening that to me are really important, right? And that is from the lens of a physician. At the end of the day, in order for us to realize the benefits of a value-based model, it does require kind of the heart and mind and engagement of the clinicians, right? And as someone who's been a practicing physician for a lot of years, you no doubt you're not there to save your patients money, but you do reduce a lot of medical misery, and that medical misery that you reduce or eliminate because of the work that you do to care for your patients, both in the exam room and out of the exam room, does in fact save them money. And so there, the idea of us living in a world of value and doing the right thing for patients, and allowing them to kind of live a better life is really consistent with the entirety of the value movement. So we're thrilled to be a big part of it. One of the things that I think is really important in the context for how we think about where we are in the entire iteration of value-based care is really the will and intent of provider organizations to move down this path, right? As VillageMD, we're a national primary care physician organization. We wake up every single day, and everything that we try to do is to make life better for the doctors and the patients and the clinicians that we serve. And today there's 1.7 million patients that we care for across all patient populations, ranging from Medicaid to commercial to Medicare fee-for-service to Medicare Advantage. And our wake-up focus is to really make sure that we're changing the way that we think about primary care to one that is proactive and helping patients understand what may be going on with them and their conditions, and not just constantly reacting and waiting for them to get sick. We're trying to introduce a model of being 24/7 available to our patients, because if we're ultimately going to drive the optimal level of experience, quality, and cost, which is, I think, the overall equation or the variables in the equation around value, then we have to recognize that the people who are dealing with chronic conditions or dealing with health conditions are dealing with those conditions 24 hours a day, 7 days a week. And if we think that we're going to solve their problems by having office hours only between 8 and 4 p.m. and no availability at lunchtime for 5 days a week, we're kind of kidding ourselves. And so we wanted to create a model that said, how do we make sure that we're proactive, we're high touch, we're with patients every step along the journey, we're 24/7 available to them, and frankly that we're also working with other parts of the healthcare ecosystem in a way that's consistent with this focus around the patient experience, quality, and total cost. I will say we're incredibly encouraged by what has been done in the value movement around Medicare Advantage. Mark, I think back 15 years ago to running a Medicare Advantage plan and us talking about VBID as we were thinking about the pricing of our products every year. And on one level, it's phenomenal that you, as a pioneer in this area, have kind of helped drive this. It's also, frankly, in many ways, a sad statement of where we are as an industry, that something so blatantly obvious is now taking 15 years, 20 years, et cetera, to kind of work its way into the fabric of how we think about the entirety of the healthcare ecosystem. And so very serious kudos to you for never relinquishing on that, because I think you know how important it is. But to me, I think that the overriding concept that I think we have to all acknowledge, regardless of whether we live in the payer space, whether we are a health system, whether we are an independent physician group, is that anything other than value, frankly, is a model that's frankly tearing away the fabric of what can be done in our healthcare system, and I'll argue in our society. We want to, as VillageMD, we applaud what CMMI came out with, the focus on addressing health inequities. We're incredibly proud that in an announcement we made last week to to go into the building of 1,000 full-service primary care clinics in partnership with Walgreens. Over half of those will be in medically underserved communities, whether it be in urban underserved or frankly rural underserved. And a recognition that if we're going to ultimately address the $4 trillion healthcare system that seems to be increasing at exponential rates every year, that if we're going to change the trajectory, we've got to create a different model of care delivery. The good news is that in that $4 trillion of spend per year, we know that it's less than 1 in 5 Americans who have chronic disease that drive 85% of that spend. When you look at the 1.7 million patients that we serve across all of our different populations, and you kind of break down those patients and the disease states that they have, and those that therefore realize all of the complexity or the medical misery, or therefore drive the cost of our healthcare system, 91% of the total medical spend that we manage today in our Medicare populations is tied to patients who have COPD, CHF, and diabetes. There's obviously a lot going on with all those patients. Those aren't the only 3 things, and so we can't just be significantly laser-like and just addressing whatever issues they've got around having a rescue inhaler as part of their COPD treatment. But the reality is that we know who these patients are. On the commercial front, we know that those same patients that have those same disease states constitute 41%. And so, I will say that when I think about the will and intent of a healthcare society and a healthcare system, we know where the biggest opportunities are. We know that if we're ultimately going to drive to a model of value, we have to be not just reacting to care. We can't just be setting up other joint ventures that proliferate a rising healthcare cost curve. And we have to be doing the right thing for patients, thinking about this idea of patient experience, quality, and cost. So with those opening comments, I'll turn the microphone over to Jay.
Well, thanks, Tim. And Mark, thank you very much for teeing this up. I love the idea of batting cleanup here, because you all have already thrown out all the shocking statistics about how much we spend in healthcare, and so looking for some solutions. Our organization has tried to be a part of those solutions by really emphasizing primary care up front. As Mark said, I represent the Direct Primary Care Coalition, which is a coalition of over 1,500 practices around the country that use the direct primary care model. I'll talk a little bit about what that is in the first place. But what I really wanted to talk about at first is the fact that has been already laid out here pretty well. As a part of the total cost of care, primary care has been incredibly undervalued in this country. We spend, as Mark pointed out, $4 trillion on healthcare, and only 5 to 7% of that is primary care spend. What would happen if we just doubled that? So sort of our mantra is to work with other parts of the healthcare ecosystem to realize that primary care maybe shouldn't be the gatekeeper in the process, but maybe your primary care doctor and your primary care organization ought to be the spirit guide to the rest of what is a very complicated healthcare system. And I think at the end of the day, if you were to ask sort of what separates direct primary care from other parts of primary care, it's essentially a payment model that is a value-based model that says, instead of paying fee for service for things that are done to you as a patient, we're going to pay a flat monthly per member per month fee to the doctor directly, whether that be directly from the patient, directly from an employer as a part of an employee health benefits plan, or as a part of a Medicare Advantage plan that is trying to improve primary care and patient care. So, the payment really isn't for things that are done to the patient, as part of a fee-for-service arrangement. It's outside of fee-for-service. That payment goes to create a relationship, a long-standing relationship with a primary care doctor. And I think Mark would probably attest, that's really kind of where the magic happens. And, you create that glue, that stickiness between the patient and the doctor. Not to say that insurance and other parts of the system aren't important, because they are. Obviously, not everything is going to be done in primary care. But in primary care, we find probably until the end of a lifespan, about 90% of the care you're ever going to need is going to come from that primary care setting, or it should. So a little bit about the coalition. We started at about a little over 10 years ago as the Affordable Care Act was moving forward. The words direct primary care actually were first, sort of printed in the Affordable Care Act, where in Section 1301A3, which is part of where they describe the essential health benefits, it says that, if you have a qualified health plan and a direct primary care relationship, and based on a model that was being promulgated out in Washington State, that those two together can meet the essential health benefits as a unit. So the insurance, the qualified health plan doing what it does best, insure against risk and more expensive specialty care. The primary care being paid upfront in a monthly membership fee covers routine care. If you think about splitting up your car insurance from the rest of your insurance, you don't insure windshield wiper blades and tires and oil changes. You insure against risk. You insure against accidents and liability and things that you can't predict. Things that we can predict are that we need primary care. We should be going in for screenings. We should be doing preventative care. So the idea here is to front load the system with primary care. And the proof has been in the pudding. We talked a little bit about, the experience during the pandemic. And unfortunately, a lot of primary care practices, had a really hard time during the pandemic. They had to flip some kind of virtual switch and all of a sudden go to telemedicine. 90% of our practices were doing telemedicine as a part of the routine part of primary care, and so when the pandemic came around and offices were shut down, there was no switch that needed to be flipped. I mean, I've had a direct primary care doctor for almost 10 years, and I think I've only been in to see him 5 times. The relationship exists virtually, whether we do it over the phone, whether we do it, in a conversation through a secure text portal. That really is sort of, again, the business of the doctor and the patient. So, really trying to put that technological foot forward, using all of the resources that we have to make sure everybody has a good care. So if we look at direct primary care today, as I mentioned, there's, at least in our world, there's about 1,500 high-functioning value-based practices in almost every state in the country. We go from practices as small as Dr. Marguerite Duane's practice here in Brookland in Washington, D.C. She's a micro practice of less than 100 patients, to Everside, which has 400 clinics in 34 states around the country and covers 530,000 lives. In the news recently, Iora, which has been one of our leading practices and works very closely with a number of Medicare Advantage providers, Humana and Tufts and others. People are paying attention. Iora was just purchased by One Medical Group for $2.1 billion. Yes, that's billion with a B for a primary care practice. That, considering that Jeff Bezos only paid $200 million for the Washington Post, seems like a pretty substantial investment. But why are they doing that? I mean, one of the things that Iora has been able to show in their claims data, working with Boeing and other employers, and Iora and Direct Primary Care Coalition have both been members of Better Medicare Alliance almost from the start, and we certainly appreciate all the work that MA has done to sort of really overvalue primary care as opposed to other parts of the system, because they get that value equation. But the data that we have out there, and I think there's been a document sent around to you all, has been, don't take our word for it. Listen to the Society of Actuaries. Milliman did a report for them last year that showed some pretty stunning results, and these results are bolstered by some of the results that Iora has had with Boeing and other large employers. They have reduced the cost of claims for employers by as much as 20% off the total cost of care, with 40% fewer ER visits, 53% reduction in ER claims cost, a 25% reduction in hospital admissions overall on an adjusted basis. That survey did point out that actually 99% of DPC practices that were surveyed were doing either virtual consults or telemedicine prior to the pandemic. And even when you get to medications in states where physician dispensing is allowed, 57% of these practices are dispensing meds largely at a cash pay price outside of the cost of insurance reimbursement at significantly reduced prices, often about $5 for a 30-day fill for primary care maintenance generic drugs. The average monthly fee for a direct primary care practice is $73.92, which is about the average price of a cell phone bill here in the United States. What are you getting for that? You're getting a personal relationship with a physician, same day and next day appointments, and vastly improved access. I hate to say 24/7 access to care, but a lot of docs, really strive to do that, and largely it's you're a phone call away from your doctor. But at that price point, understanding that employers pay that fee and Medicare Advantage pays that fee. I mean, largely these services are offered as a no out-of-pocket cost benefit to employees and to Medicare Advantage beneficiaries. So you're getting first dollar coverage for 90% of the care you ever need for $70 a month. I'd say that's pretty high value-based primary care. So that's a little bit about what we've been doing. We're really excited about the direction that CMMI is taking. We totally agree there needs to be a focus on health equity and value-based care and the real use of technology to transform where we're going coming out of this pandemic. So we're excited about it. A number of our practices are taking part in the direct contracting and primary care first demonstrations, which are they're not quite DPC, but they're direct primary care like. So we're here as a part of the ecosystem to say, let's put primary care up front as a part of the healthcare ecosystem. Let's really put it in a place where it can guide you through the rest of the system that you'll need for the rest of your life, and really create as much value as we possibly can. So that's a little bit of our story, and I'm really happy to be here today to engage in this great conversation. And I'll put it back to Mark.
Jay, thank you. I'm inspired by all of your articulate comments, and I'm actually going to go around the Hollywood Squares horn with questions for each of you, and then continue to encourage the audience to put in some questions or comments into the chat. So, Jeff, first to you. I may have told you that when I was testifying in front of Congress, they mentioned that I was one of the few people to get in the middle of the virtual firing squad of healthcare. And one of the things that's impressed me so much about the Taskforce is your willingness to become multi-stakeholder and multidisciplinary. And I know that's been a priority of yours. I'm curious while people like talking about value-based care, I'm curious to see about what your views are in terms of bringing along the key stakeholders that may not get like each other very much in some of these issues, and your view into the future and thinking about whether we're able to appease some of the folks who've resisted value-based care and actually see it, some of your frustrations that you mentioned come to fruition.
So I would say it's been interesting to kind of watch the progression of the Taskforce dialogue over our life cycle. I think we very early on had early adopters who were committed to this move, understanding that there were positives and negatives from a business standpoint of going in this direction, but seeing it as the right thing to do. Our leadership who created the task force felt very strongly about having those multi-stakeholder voices around the table for educational and awareness purposes. Rick Gilfillan, who was our founding chair and the first director of CMMI, talks about his time at Medicare and they didn't really interact with beneficiaries very much and found that interesting. And so when he designed the structure of our organization, he felt that patient consumer voice needed to be at the table from the beginning, middle, and end. And we've all learned a lot about kind of the different perspectives that are brought to the table. The other experience I'll have is you think about how the industry is changing. When the task force first started, our member organizations had what I would call a pod of people in their organizations kind of working on these issues if they weren't a company that was fully devoted to the move to value. And so when those pods of people from our different members came together, they were speaking a common language. Now that's a bit more widespread, and we're glad to see that. But I think you have to just kind of go to the table and hear each other out and find common ground. And I think that the task force in its public pronouncements all of those have been vetted through that 4P leadership process. Where it's challenging is also recognizing that all of those stakeholders have their own advocacy agendas too, from a public policy perspective. And so making sure that we keep value kind of front and center for folks and try to move that forward in light of other priorities continues to be a bit of a challenge, especially given kind of the scope of some of the legislation that's being currently considered on the Hill. But I think the move to value and the wins that we're seeing and the greater participation across all of the populations has really been something that we have centered around and make sure that we continue to have a forward-looking agenda to address the issues that are critical to keep it moving.
Thanks, Jeff. Tim, this is a perfect tee up for me. So thank you for the kind words, Tim. And you're old enough to know what it is to sound like a broken record. So I've been telling the same story for a very, very long time and been referred to the tortoise in the healthcare transformation race. Yeah. So one of my favorite quotes comes from a book called The Jungle by Upton Sinclair, who said, "It's difficult to get a man to understand something if his salary depends on him not understanding it." So one of the things that most impresses me about VillageMD is, and Jay had mentioned, he's along with me, wants to put the wrecking ball to fee for service, at least not in a clinically driven way. I'm just curious about how you have been able to maintain that culture among your clinicians. And maybe if you can comment a little bit about how we might be able to deter the more is better ideology that not only fee for service clinicians have, but I have to admit, many well-insured Americans, particularly if they're getting the deal that Jay suggests, they might come in as they would do in the past, coming in their chief complaint, I need an MRI. They don't even tell me where their pain is or what joint they need, and they're just telling me what to do. So I know this is a fundamental construct of the VillageMD idea, and we're curious to hear both how you got to where you are and where you think you're going.
Yeah, so I will say, Mark, it goes back to something I said in my opening comments. It's about the will and intent, right? I will argue every provider in the United States should be moving to a capitated or risk-based model, like flat out, full stop. And frankly, I know that's not a very popular opinion, but it's okay. I'm comfortable saying it's really where we need to go. It's where we should go. And when you do that, then the entirety of your organization starts to think and act differently, right? So we talked earlier. A number of you made comments about this time period of the pandemic. So during the pandemic at Village, because we live in a fixed payment world, a capitated world. When COVID, we all kind of came to the realization this was going to be around for more than 3 or 4 days. The perspective that we had was, how do we make sure that we are taking care of all of our patients? How do we make sure we're taking care of those who are most vulnerable? Because I think we all realize what would happen to those who are most vulnerable during the time period of this pandemic. And oh, by the way, their COPD, CHF, depression, you name it, didn't go away because COVID hung around, right? And so for us, our focus was, how do we make sure that we are taking care of our patients and helping them avoid the emergency room, avoid the hospital, unless it's absolutely necessary, because the risk of them getting there and having further complication is only going to be greater, right? And so our whole focus, from every clinician to medical assistant to nurse, pharmacist, social worker, et cetera, was all around optimizing what we do with the patient. There are a number of other organizations during the same time frame who were trying to figure out when they could, quote unquote, reignite demand, right? I think that when we talk about, when you ask the question about what we do and why, culturally we're able to grow and expand and maintain things, is because we wake up with that will and intention of making life better for the doc and for the patient, and keeping it as simplistic as that, and trying to solve ultimately all the problems that we know that the patients have, right? For those of us who've been around for a while, the social determinants of health, and those of us who've lived in a risk model, we just thought that those were really important things to be paying attention to. I think it's phenomenal now that we're getting a line of sight around it. And we also have kind of legislative and regulatory support to actually address these issues, because unless we think about the patient holistically, we're not going to drive to a better set of value, right? And so I say all that, Mark, to then answer the last part of your question, which is, the way that we have built this culture is by having physicians lead everything we do, by democratizing data and being transparent about data and letting the physicians see themselves where all of this medical misery and therefore waste exists in the system. And it just gives them the opportunity to be that much better equipped, that much more confident, to be able to have the conversations with patients that are not, you don't need to have a third MRI, right? You don't even need the first one. And let me tell you why, right? But we're also giving them the time and the tools to be able to have these kinds of conversations. And patients have come to expect a different level of model and engagement from us, and one that's helping to help them navigate the entirety of the system, which, if we're all being honest, most of what happens today in the world of primary care is the doc sends a referral and the patient's then left to navigate the system on their own. And so we've made investments in resources and people and technology so that the patient doesn't need to feel like they're on this journey entirely by themselves. And when you do that, you build this trust, you build this credibility, and frankly, you build a better culture where physicians are knowing that, hey, we're doing absolutely the right things for the patient, right? The docs in the Village model don't get a report that says, hey, you didn't refer to our new orthopedic group enough. The docs that work at Village get to have complete line of sight on all of their patients to dive in to see, okay, how many of my patients that have a behavioral health condition, how many of them are we proliferating a model where they can actually have access on a timely basis to a therapist or a behavioral health specialist, right? So it's a different way to think about what you do. And I think when you do that and you design it around how doctors, frankly, would be designing a healthcare system, I think that's what leads to the culture that we have.
That's really helpful. I know you have a time constraint, so Jay, I'm going to have you listen to this question as well. But for Tim, one of my big concerns over the years in trying to convince public and private payers, including Medicare, to lower out-of-pocket costs, that someone has to pick up the bill. And my mother predicted correctly that when you lower out-of-pocket costs, people use the stuff more often, thus raising total cost of care. And the way you pay for total cost of care is either raise premiums on everyone, which is a political non-starter. You push deductibles down the road on other things, which keeps me up at night.
Yep.
And the last thing is the board at the VBIT Center forced me to become a low-value care guy. And I'm curious, in both VillageMD and in your groups, Jay, is it possible that we might be able to move forward with the same type of benchmarking and data to not only do the things that we should be doing, like diabetic eye exams, but also start holding clinicians accountable for doing those things that might be classified as a D rating by the U.S. Preventive Services Taskforce don't do, or noted by the Choosing Wisely initiative, where clinicians themselves tell them not to do that. We published a paper showing it's $5 billion over 10 years in Medicare on the services that the same task force that tells us the things that are so good they should be free are things that we should never be doing. And if we're really going to do more of the good stuff and less of the bad stuff, I applaud all the efforts, including the task force members as well, in terms of what we're doing to push high value care. But there's always that actuary, Tim, who goes, there's Fendrick again, saying that we should cover something more generously, and then total cost of care goes up. And since I've never been effective at lowering prices, we have to find a place to offset that. And I mentioned to you when we first met that low value care removal is something that luckily has bipartisan and multi-stakeholder support. So you and then Jay, you could follow directly, and Jeff, if you'd like to chime in too, that's perfect.
Yeah, so I think Mark, you're as always sort of on the cutting edge of some of the thinking around this, and clearly it's sort of this blend of your clinical policy and economic mind. But I'm from a small town in Northeast Wisconsin, so my brain isn't as big as yours, and so I think about things in a more simplistic way, which is that when you move to a capitated world, right, you then get to move out of the realm for how you think about each touch point or engagement with a patient, away from the construct of a traditional billing model. Right. And from that standpoint, what we have learned, for example, is that with our COPD patients, what we have learned is the more that we touch these patients, the more that we engage these patients, the more we see ER visits come down, hospitalizations come down, et cetera, right? And so while I completely agree with everything you're saying, I think that at least where my view is, living on the ground in lots of markets around the country, is that we're still at the point of getting physicians to understand and appreciate that moving to a risk model is a good thing. It's going to incentivize the right innovation, identification of the patients who need to be seen more than 3.6 times per year, and seeing them and touching them. And sometimes even if there's not a specific clinical engagement, just the fact that you care about the patient and you're checking in with the patient, which I'm sure you've done throughout your career where you weren't paid for that service. It's a constant reminder of the opportunity to help that patient, and that patient knowing they've got a system behind them that's working for them. And so I don't mean to sort of semi-punt your question, but more sort of say, like, from our lens, moving towards risk is where we have to get the industry, and sadly, market by market by market by market, we're having to introduce that. We're able to partner with a lot of forward-thinking plans around some element of value-based insurance design, and really starting to get smart about some elements of co-payments that will drive some of the right behavior. But then it's also making that when you're living in this capitated world, getting physicians to think about off of the hamster wheel of the fee-for-service medicine and into a spot of, I can actually impact this patient's life beyond the four walls of my clinic, and now I can actually turn my mind to what those things can be. I personally believe your thought process is 100% right, but it's tied to a fee-for-service world, and I'm trying to move to a full risk world everywhere I can to get people to think differently beyond the realm of a billable account.
Yeah, so as we turn to Jay, I'll just say that having lived on both sides and living through the managed care backlash of 35 years ago, is that fee-for-service, we do too much of everything. There are obvious concerns in full capitation that we'll do too little of everything, which is why, because I'm so much of a harmonious person, is that we should reward people for doing the things they should be doing. And to pay for it, we should benchmark and potentially penalize the performance of services that don't hold the same clinical evidence for that.
Yeah,
so
well,
it's
to that point, Mark, right? So in our seal, interestingly enough for us, we see this every market we go into. The baseline admissions per thousand for the COPD patient population that we serve starts at about between 850 to 900 admissions per thousand, right? So 1,000 COPD patients, there will be 850 to 900 admissions for those people during the span of a year. As we watched physicians start to engage around the model and start to think beyond the four walls of the exam room in a more effective way, in a holistic way, with all these other resources and support around them, what we see is usually over a 2 to 3 year time period, the COPD admission rate drops below 400. So a 55 to 60% reduction in admissions per thousand with patients who have COPD as a result of a much more proactive high-touch model. And I think, the reality for me is that when we start to, as a society, have that be the norm, then I think we're in a much better spot to address so many of these other low-value activities.
Jay, a lot of you to react to. I'll just add one more thing through the chat is there are concerns that these pay for direct primary care practices may lead to some type of discrimination, so to speak, in people who can afford to get the best care, and those who may not may be segmented into a tiered system.
Yeah, I've heard that too. And I've got a bridge in Brooklyn you could buy from me if you like, but you can throw any data you want. I think you quoted Upton Sinclair, so you gave me permission to go very deep here. So I think the conversation kind of needs to flip to the data. The data is all important. Okay, we've shown you some data. Let's talk about this. So we reduced the total cost of care for employers by 20%. if you double the 5 to 7% spend that we have on primary care, and then take 20% off of the 4 trillion, like back of the envelope, what's that number? I mean, maybe that's not exactly right, but that's what we're talking about. And to even getting into Medicaid, what Medicaid plan wouldn't pay $70 for each one of its members to have a 20% reduction in the state's outlay and cost, right? So there's good conversations to have, but I think we're asking the wrong questions in the data. As a primary care doctor, you probably know that A1C isn't really a good measure of how a patient's doing. I threw up on the chat something that I think everybody should read. It's a new set of measures developed by Dr. Rebecca Etz from Virginia Commonwealth University, who is not an MD. She is a cultural anthropologist, but she worked with a lot of people in family medicine to develop these 11 questions that are sort of like a CAP score. What does it really mean to the patient to be better? What does it mean to be well? And we ought to be asking these questions about what that whole person care really means. And I won't go through all of them, but they're questions about, how are you doing? How are things in your life going? Do you feel like the care that you were given is valuable? Do you feel like you were a partner in your care? So, these are very, very important questions that never wind up in, somebody's spreadsheet about what the baseline was when we started our contract. The reality is, the value equation of doubling our current spend on primary care, which could lead to a dramatic reduction in downstream expenses for conditions like Tim mentioned, like COPD. We're not only about stopping type 2 diabetes from arising in patients that are pre-diabetic. We're about turning it around to make them not pre-diabetic anymore. And this is happening by applying some good old-fashioned primary care. And the fact is, if there's absolutely no professional, clinical, or financial incentive for anybody practicing in any of these capitated models to shift somebody on to the next specialist, to check off a box. And as far as I'm concerned, most of our patients, are free to vote with their feet. They're not subject to, they're not subject to agreements that last for a year or more. They're subject to agreements that last 30 days at a time. And if they decide to quit in the middle of the 30 days, they get half of their money back. So, and as I said, by and large, employers, Medicare Advantage, and payers are paying for, I don't have any data on this, but I would guess more than a half, probably 3/4 of these arrangements, if you look at the number of lives in these situations. So, I think it's time to sharpen our pencils and take a fresh look at what kind of data we're actually collecting to measure the value of care.
So really good points, Jeff. In a second, I'm going to ask you if there is an ask that you might have or your constituents might have of Medicare Advantage organizations who are on the call today. I think, I've told you I didn't know the word ask was a noun until I started coming to DC. So if there is something that a drum that's being beaten by the task force, I think that'd be interesting. And Jay, for you as well. But I know I've already got your blood pressure up a little bit, and I think this one might add to that in terms of a question from the chat. How would you address the argument that direct primary care and even full capitation, if Tim is listening, may reduce price transparency through the inability to see specifics? I knew it. Look at that smile, everyone. But anyway, I know you have the answer. So why don't you please give us the answer to that concern?
So what price transparency? It's $70 a month, and they will publish a list of 150 meds for $5 a month. And I mean, you're seeing what you're paying for. And the minute an employer or a Medicare Advantage plan thinks that that's not a value-based service, they end the contract. I mean, I don't know what kind of more accountability and risk you can talk about there. While these practices might not take, insurance risk, they're at total financial risk for the services that they provide. If they don't provide the services, then they get fired.
Any thoughts on my comment, the question to Tim on your willingness to hold your primary care providers accountable for the care that we know is quite pervasive that gets done just because it does get done?
Yeah, absolutely. And in fact, one of the things that we suggested to CMS when they promulgated the CMMI demonstrations on primary care first and direct contracting was, that they actually look at the accountability measures, with very strong teeth and say, like if you're spending more, if your patient isn't actually the cost of care for your patient downstream using the regular Medicare measures is actually going up or even, let's say it's staying at even, you can't be in the program anymore. Give them 3 years, and if you can't meet that standard of CMMI where you're reducing the total cost of care by a fairly substantial margin, you shouldn't be in the practice.
So before I jump it over to Jeff, do you have an ask of the Medicare Advantage organizations on the phone from the coalition?
We want to partner with you. We're doing it in small numbers now, I would say, and I think we're really happy to see Mary Beth Donahue's leadership here. We've known her for a long time. She's a terrific addition to this team, and if you look at the incentives, if you look at the data about the care that these practices were able to provide, particularly during the COVID pandemic, coming out of that in the new era of a transformative healthcare system, we're open for business, and not just the larger practices. We have thousands of practices in almost every community in the country now that would be willing at the right payment rate, at an increased level of primary care payment for a reduced level of downstream spend, for that kind of promise and value equation to work with Medicare Advantage, to work with employers. And one last sort of general ask is that, the Affordable Care Act and now over 35 states have defined these practices as medical services that are regulated not by insurance commissioners, but are sort of like outside of insurance regulations. The last regulator that doesn't look at this is the IRS. So in your dreaded high deductible health plans, you're actually not allowed to have a direct primary care plan now, because if you do, you're not allowed to fund your HSA if you have a high deductible health plan and you get this kind of care. So that's a huge problem.
You're making my blood pressure go up. So Jeff, you've got a minute, and Tim, I know you're in a concourse, but when Jeff's gone, if you have a closing ask or comment, I understand you may not be able to, but if you're hearing us, we'll let Jeff go and then you, and we'll close this thing out.
So, sounds good.
So thanks, Mark. And just before I answer your question, I did want to echo something Tim said before. I think the Taskforce thinks about the move to value with the yin and the yang. We want to make the models and the arrangements attractive for investment and participation, but we also have to make fee-for-service more painful. So the fee-for-service off-ramp is a critically important topic, really, for this. And I think to go to your core question, when we look at low value and no value care, fee schedule reform is something that's there, right? You've talked about the list of services that really shouldn't be provided. Well, why don't we remove them from the fee schedule? So if there's an ask I have, it's like, let's look at those things. Let's reduce them. Plans, I know plans by and large follow the fee schedule for purposes of coverage, but let's take on that food fight and let's try to reinvest in primary care as a result of what we can do through fee schedule reform. So it is a policy lever that's out there. I think it doesn't get as much attention as it should, but it certainly is well within the purview of MA plans to look at that and just figure out what they're going to cover with their provider panel. And I think that's a good step in that direction of creating some pain for fee for service.
I did not plant that response. Those of you who know, I've been talking about this for a while, and there is a section of the ACA that only about 5 people have read, Section 4105, that gives the Secretary of HHS the authority to not pay for Taskforce D-rated services as a place to start. And we could certainly build for there. So we should chat. Tim Berry, final comment.
Yeah, thanks, Mark. I would just say that from my view, I as someone who's run a Medicare Advantage plan, I think Medicare Advantage is really a beautifully designed model and beautifully designed program. And at the end of the day, it rewards those organizations who deliver a better experience for the member or patient, who deliver higher quality, and can do it at a lower total cost. And so it's a great equalizer. It's a great program. The greater, more efficient you are in your ability to do that, it rewards you disproportionately, because you get to then, through Medicare Advantage, obviously offer better benefits to then attract more and more beneficiaries. And so, I think that the MA plans have done a phenomenal job of really engaging at-risk providers and helping organizations like ours proliferate. And I think that there's a wonderful symbiotic relationship there. And all I could just keep preaching everywhere is more and more capitation, really, and getting more and more providers into a capitated model and a capitated world, because it does free you up to think very differently about the value you can ultimately deliver to your patients. And frankly, I think every American deserves that. And that should be the guiding principle we have.
Thanks, Tim. Don't miss your flight. We are at time. I can't believe how quickly the hour flew by, but I think this conversation gives me optimism that we might be able to build a better health system through value-based care and through the work of Jeff Micklos, Tim Berry, Jake Keese, and all of you participants moving from volume to value. I thank you for your attention. I thank BMA for inviting the four of us, and wish you all a great remainder of the conference. Thank you very much.
Thank you, Mark.
Thanks, Mark.